Hello, this is Dr. Kim Jeong-gil. We are going to cover the topic Unusual Extraction Treatment. This is the first part, Unusual Extraction, where the other teeth are extracted instead of premolar. In particular, if there is a pathological problem or the orthodontic treatment is needed, the mandibular incisors, maxillary incisors or first molar can be extracted. So today, as the first part, let's learn about the introduction and mandibular incisor extraction. This patient has slightly protrusive lips. By the way, there is severe maxillary anterior crowding and slight mandibular crowding. In this case, we should extract the premolars to solve the protrusive lips and crowding. Possible treatment plans are whether to extract the first premolar, maxillary, first premolar and mandibular second premolar or second premolar. This may change depending on protrusive lips and the level of protrusion of the anterior teeth. However, for this patient, endodontic treatment was already made on the mandibular first molar. Severe dental caries are observed in the maxilla. The maxillary first molar has already been treated. In this case, is it better to extract the first premolar and then implant the first molar? We need to think of it. The problems with non-extraction treatment for this patient are severe anterior crowding, protrusive lips and dental caries. Since the lips are protruded and crowding is severe, extraction is necessary. Following are the problems of the premolars extraction case. At that time, what would happen to the teeth which have already been treated after premolar extraction? Restoration is necessary. Extraction may be needed later. The implant would be made later. In the 4 first premolar extraction cases, because the first molar has to be restored, and the third molar needs to be extracted, there would be some problems. However, in orthodontic treatment, if the first molar with severe caries are treated, even though the size of the first molar tooth is large, we could solve the anterior crowding and protrusive lips by using extraction space. Of course, it will take a lot of time to close the extraction space and will not be easy. However, in the case of natural dentition like this, there are pros and cons for the extraction. This is a case where the treatment was completed by extracting the maxillary first molar on the right, and the second premolar on the left, and the 2 mandibular first molars. However, in the case where there is anterior crowding, the crowding can be solved by extracting the first molar. At this time, Yon to FH was 104 degrees before treatment. 104 degrees means that the maxillary incisors are lingually inclined. If the first premolar is extracted, this 104 degrees will get even worse. In many cases, if the maxillary anterior teeth are lingually inclined like this, the second premolar would be extracted. However, if the first molar is bad, the first molar would be extracted and the crowding would be solved by using extraction space. Then the anterior teeth and the first molar would be far apart. It is possible to minimize linguversion of the maxillary incisors. The mandibular incisors would be the same. Lone to MP angle is 100 degrees, it is labially inclined. By extracting the first molar and closing the extraction space, anteriorly placed mandibular incisors move to the proper position. So we decide whether to extract or not the maxillary third molar extraction or premolar extraction. Next, what we are going to study today is unusual extraction. Unusual extraction is classified into anterior teeth extraction and the first molar extraction. Anterior teeth extraction is classified into the mandibular incisors extraction, maxillary incisors extraction and first molar extraction. Today in the first part, we are going to cover mandibular incisor extraction. So when is the best time to extract mandibular incisors? I perform extractions in the following cases. 1. Severely malpositioned mandibular incisors. 2. Anterior Bolton ratio discrepancy. 3. Severe mandibular incisor crowding. 4. 3-incisor case. 5. In the case where there is crowding in the mandible with class 3 anterior cross bite, the mandibular incisors would be extracted. In this case, the problematic teeth would be extracted, and it is easier to perform orthodontic treatment and stability after treatment can increase. In the first case, we will check the case of extraction of severely malpositioned mandibular incisors. There is anterior crowding. In particular, the mandibular tooth 42 is lingually inclined. In this case, in the differential diagnosis, the first premolar would be extracted. But here, we need to think over whether to extract the tooth 44 or 42. As such, the crowding was so severe that the tooth 42 moved inside. If a first premolar is extracted, even though a canine moves backward, a lateral incisor should be placed in the proper position. In other words, the tooth must be placed between the arches. In that case, we should look at the lingual side. Even if the mandibular lateral incisor is placed in place, can the lingually placed root be in the proper position? In the maxilla, root labial movement is possible. Although it is possible somewhat in the mandible, because the mandible itself is a compact bone, root labial movement would be restricted. So in the case where there is severe crowding without space, it would be better to extract severely lingually inclined lateral incisors rather than first premolar. In this case, we must make a diagnostic setup model, and it would be important to know where the occlusion roughly places. In the first premolar and the second premolar extraction cases, there are no major problems. However, in the unusual mandibular incisor extraction cases, a setup model must be used. A patient with protruding mouth and crowding before treatment has a good profile and intraoral appearance after treatment. Second, if the anterior Bolton ratio discrepancy is severe, one of the mandibular teeth would be extracted. This patient has severely bad gums and the mandibular anterior crowding. The treatment was over, but overbite and overjet in the anterior region cannot be good. This patient's Bolton ratio should be checked again. The sums are 38 mm in the mandibular 6 incisors and 43.5 mm in the maxillary 6 incisors. Then the anterior Bolton ratio would be 87.4%. We should evaluate how many millimeters are excessed in the mandible. The sum in the maxillary 6 teeth is 43.5. Multiplying the maxillary part by 38 plus 20 by 100 will be 77.2. 20 is unilateral. It is insufficient by -2.2 per side. It means that space is needed. The tooth size of the mandibular 6 incisors is 2.2 mm larger per side than the maxillary 6 incisors. In other words, if you put the other side together, it means that it is 4.4 mm bigger. It is generally said that the size of the mandibular incisors is 5 or 5.5 mm. It would be much better to extract one of the mandibular incisors. In particular, the tooth with prosthesis was extracted. Temporary teeth were placed there, and then the extraction space was closed. The patient gets to have class 1 canine relationship and proper overbite and overjet. In the third case, if there is severe anterior crowding, one of the mandibular incisors would be extracted. Again, of course, this is the case where the anterior Bolton ratio is not matched. This patient has slightly protrusive lips, but the profile is not so bad. There is a slight maxillary anterior crowding and mandibular lateral incisors crowding positioned posteriorly. What should we check at this point? I always checks the midline, then overbite, overjet, and canine relationship. Now, the canine relationship on the left and the right is class 1. After orthodontic treatment for this occlusion, the class 1 must be maintained. How would teeth with mandibular anterior crowding be aligned? Treatment would be completed when the mandibular incisors are placed more labially. If the canine relationship is not class 1, the canine relationship should be changed into class 1 and then consider the anterior overbite and overjet. For this patient, it is better to extract one of the mandibular teeth because the canine relationship is class 1. In this patient with non-extraction, the problem would be protrusive lips and tooth size discrepancy. The problem is that when the premolar is extracted, the bite will deepen because of the large combination factor. Even if the premolar is extracted, the anterior Bolton ratio discrepancy cannot be resolved. It is because the canine relationship becomes class 1. In this case, one of the mandibular incisors could be extracted. If one of the mandibular incisors is extracted, the maxillary midline and the mandibular midline is not centered. The midline of the maxilla should be centered on the facial midline. However, it doesn't matter whether the mandibular midline and the maxillary midline is centered or not, if the lateral occlusion is good. So treatment is over. This is the case where the canine relationship is maintained, as class 1 and anterior crowding is resolved by extracting one of the mandibular incisors. The maxillary midline should be placed on the center of mandibular central incisors. That is, the midline is not centered on the center of the mandible. In the fourth case, one of the mandibular incisors can be extracted in the 3 incisors case. In the case of 3 incisors, this patient has severe maxillary anterior crowding and mandibular anterior crowding. In general, the possible treatment plan for 3 incisor cases is to extract 3 premolars. The maxillary first premolar and mandibular premolar 34 with crowding would be extracted. In another case, if there is mandibular anterior crowding, the mandibular lateral incisor with crowding would be extracted. It means that one of the mandibular incisors would be extracted. So the treatment is over. The maxillary crowding and the mandibular anterior crowding is resolved and the occlusion is fit. It is a panorama photo before and after treatment. At this time, we need to decide which tooth should be extracted. In the first case, the worst tooth would be extracted. In this patient's case, tooth 42 and another tooth are fused. In this case, if extraction should be performed, it would be better to extract the fused tooth than another tooth. In this patient's case, we should think about whether it would be better to extract tooth 41 or 42. What should I consider? In this patient, tooth 41 has severe gingival recession. If the tooth 42 is extracted, it is hard for the root and the adjacent teeth to be parallel to each other. So in this case, it would be better to extract tooth 41. Reviewing it once again, it would be better to extract teeth to solve the gingival recession and to facilitate parallelization of the adjacent teeth and the root. In general, when we decide the mandibular incisors extraction, we need to consider the following. We need to decide whether to perform reproximation, the mandibular incisors extraction, or to restore maxillary lateral incisors. Dr. Kokic noted in 2000 as following: if the mandibular tooth size is more than 1.6 mm, consideration is necessary. The first case is interproximal reduction, in other words reproximation, stripping as we mentioned. It becomes possible to delete between adjacent teeth. In what cases should this be done? It is when the patient has a triangular crown shape and interproximal enamel is somewhat thick. In other words, the shape of teeth matters. It would be good to reduce interproximal when there is black triangle. In general, if the anterior Bolton ratio is larger than 12 mm, one of the mandibular incisors could be extracted. In this case, the following setup model will be absolutely necessary. In another case, if the maxillary lateral incisor has small teeth like peg lateralis. Even if one mandibular incisor is extracted, the appearance will be unaesthetic. In this case, it is better to restore a large amount of the small maxillary lateral incisor. What would happen if the mandibular incisor is extracted? First, the midline between mandible and maxilla is not centered to each other. It is not a big deal. Second, it is highly likely to be black triangle, especially in the case of class 2. But in this case, a black triangle is formed. To resolve the black triangle, interproximal reduction is required. What would happen when interproximal reduction is performed? The overjet relationship would worsen. So it would not be preferable for class 2. Whereas in the case of class 3, to form anterior overjet and overbite, interproximal reduction would be a good choice. In the case of class 3, it can be a good treatment. In another case, if one of the mandibular incisors is extracted, the buccal overjet in the canine area becomes larger. In such a state, it will be difficult to obtain a canine guidance occlusion when moving laterally. We can extract one of the mandibular incisors when the Bolton ratio is not fit. But it is not preferable to extract the mandibular incisors to resolve anterior crowding. When we decide on different extraction options, the premolar extraction takes precedence. However, it can be uniquely extracted like this. One of the mandibular incisors, the maxillary incisors, and the first molar could be extracted. In this case, the tooth can be extracted if there is a problematic tooth or to facilitate orthodontic treatment. It can also be extracted to increase stability. I performs mandibular incisors extraction in the following 5 cases. 1. Severely malpositioned mandibular lateral incisor. 2. In case of anterior Bolton ratio discrepancy. 3. Severe mandibular anterior crowding. 4. In the case where one of the mandibular incisors is extracted and it changes from 3 incisors to 2 incisors. 5. In the case where there is mandibular anterior crowding and class 3 malocclusion. If the mandibular incisor is extracted, we would have good results. Thank you for watching.